All right, welcome to episode 13, lucky number 13 of the Jake Blanchard podcast. Today, I'm so excited. My guest is Leslie Kelly Hall. A little background, quick commercial on Leslie, if you will. She has been an advocate for patients. She's a subject matter expertise in many things around patient engagement, health information technology, collaborative care. She's formerly the Chief Information Officer and a marketing executive at St. Alphonsus Hospital here in the Treasure Valley. She spent her career providing a platform to promote and operationalize patients' access to their records. And she was pioneering things like shared decision-making and patient education was really underdeveloped in the industry, and advocating for all those important things. Importantly, she's currently on national advisory committees, or was on a national advisory committee in the Obama administration, currently in the Trump administration. And, Leslie she's made an impact in healthcare technology policy for patients and providers. So all kinds of stakeholders. She's a board member of St. Al's, Direct Trust, other software companies. She's got a long list of accomplishments and things. And Leslie, I'm so excited to have you today. Thanks for being on the podcast.
Thanks, Jake. It's great to be here. I'm happy to help in any way.
Yeah, absolutely. So, first, that's a long intro, and definitely from outside, like looking in, it's a lot of things. Maybe we can talk a little bit about this journey. So it sounds like from a technology standpoint to a healthcare leadership, focusing in technology, and then, obviously all the work you've done in patient advocacy. So maybe take us on that journey a little bit. What's that been like?
Oh, sure. I'll age myself in the process. But early on in health information technology, we were focused on just doing billing events, just collecting enough information about care to create a bill. And it transitioned first with nursing systems, and then clinical documentation systems, and then the electronic medical record of today. But during that journey, while I was at St. Alphonsus, I determined that honestly, everything that was collected about a patient was potentially relevant, not only to the provider, but the patients themselves. So we started gathering every single transaction every single day in the late 90s, normalizing that data and placing that data in a repository that could be accessed by web technology and then future mobile technology. And this actual gathering and normalization of the data allowed us to provide access to physicians early on, like in the late 90s, to their electronic information that came from nursing documentation, lab documentation, and radiology information, including their images. And that information was gathered and distributed at that time on PCs and on the web. Fast forward to 2004, when we had approximately 12 years worth of history across 59 different systems, and we made that information available to patients. So not only did they have access to their information for today, which was pretty common, but they saw everything that was written about them, every lab report, every medication that was given from both their hospitalization and these other systems that were connected. As a result of that, I started out thinking that that was pretty cool. Within a week of access, patients were calling their physicians' offices. What does this mean? Getting a lab result is quite confusing. You could have a negative result that means you have a disease, or a positive result that means you don't. So it's very confusing. So using data standards called LOINC at the time, I was able to connect patient education materials from HealthWise to the content of lab reports for patients real time, including their historical information. As a result of this robust education and connectivity, we had a sign up every 6 seconds. People, word of mouth, it was all word of mouth. People signing up to get access to their medical record.
It's old school going viral.
Yeah, it's as old school going viral, totally. And then what happened next is I got a phone call that changed my life. It was from a patient who called up saying how much she hated my St. Al's. And what do you mean you hate this? And she said, well, I looked at my record and there was a note from a physician. And the note said, morbidly obese, chronically non-compliant, difficult middle-aged woman will never live to see grandchildren unless she loses, on and on and on.
Wow.
She was told personally that, honey, you need to lose a few pounds. And instead, what she found out is that she was killing herself through food, and no one had told her. And in fact, the only way that she saw it was by seeing the physician's disparaging note. And I realized that access was a big deal, right? So I was lucky enough to work in, for HealthWise, a nonprofit capacity, working in the administration at that time, was working with former Bush appointees who then continued on into the Obama administration, where I was one of 3 people to make sure that the law was changed to reflect access to medical records meant electronic access, to view, download, and transmit at the patient's desire, to have patient education. And then in the next, couple of months now, in January, the work we did is now reflected on the law requiring a patient or requiring a medical record to have an API that will allow patients to access their own medical record data through an API on the app of their choice with no special or difficult circumstances to connect. Wow. So I've been involved in data liberation for patients for a long time now.
Well, and Leslie, there's probably a handful of people listening who don't live in the tech world. I know what an API is, and I know you do as well. Maybe, touch on,
Sure.
Yeah, absolutely.
So we all use APIs. If you use a smartphone today, you use an API. Every time you sign on to something, one thing, and they say, would you like to use your Google account to sign on to something else? You're actually signing on to another application program interface, another app, through a common way to log on. So this is done through common rules and standards that says, I'm Leslie in this app, I can be Leslie in that app. I have electronic medical record information that I can provide through app number 1 or app number 2 or through the Apple Store. So an application program interface allows apps to connect to a broader world based upon agreed standards and principles and rules of the road.
Awesome. And, Leslie, there's a lot going on in healthcare right now, nationally. And, obviously you've taken us on this trajectory of, IT and leadership and then advocacy, that conversation or that phone call that helped change your path, I think, in a lot of ways of going out and advocating for patients. I think now more than ever, patient advocacy should be at the top of all of our minds. There's a lot of stuff going on, and there's a lot of mixed feelings, mixed emotions, especially around COVID and what's going on. Like, what's your perspective on some of this, and what guidance can you provide, and maybe what insights might you be able to share with us?
We are in crisis on so many fronts right now. We're in crisis that is starting with misinformation and fear and distrust. It's simply not the optimistic world that we've all lived with in America. We're faced now with so many multiple conflicting information and trust that it's hard to know what the future might be. We've seen our work upended. We've seen a brute force of digital interaction come to all of us, including healthcare. Telehealth has now replaced many of the episodes of care that we're used to having in our physician's office. We might be doing that on Zoom today. We might be doing that on American Well. We are using digital information in completely new ways. We had almost 10 times the amount of total telehealth visits in the last 40 years done in 3 months post-COVID. Wow. Disney Plus did more in the first 8 weeks than Netflix had done in the first 7 years in terms of membership. Right. So we've had a digital brute force. Now, the big advantage of that has been that individuals, have saved healthcare. And I know that sounds crazy, but honestly, nobody could handle the amount of volume that COVID represented. without people doing self-care. And we've seen that those who, okay, I've taken my temperature, I have a pulse oximeter, I know when to get care, when not to get care, I know to call my doctor first, I'm going to avoid this particular treatment because I don't need it right now. In fact, Kaiser has done some studies that says I think 60% of the estimated healthcare has not taken place, with about 11% with untoward or ill effects of that group. And that's tough. We don't want people to delay care in some instances. What we all strive for is appropriate care. And that is dependent upon individuals knowing more and making decisions for themselves. COVID has taught us many things, mostly that the need for self-management is blossomed, right? It's just, we have to manage our own care, because without it, the health system just doesn't have the beds. Do the math.
Yeah.
We're seeing an explosion right now, right? And so self-care means being able to know when I need care. Kaiser Permanente has done some studies. I think it's around 60 or plus % of the care that would normally happen hasn't happened. People have delayed care. There's been about 11% of those that has resulted in bad events. So we don't want that to happen either, but we want people to be able to self-manage, self-triage, be educated, and also when they need a doctor, try something new. So this digital brute force change we've had has done more telemedicine, 10 times telehealth visits in the first few months of COVID than they had in the previous 40 years. So it's just a huge change in how we do business, not only for patients getting care, but for providers. Seeing some dramatically different approaches. So I know, Jake, you've been to a doctor's office. Have you had experience where they actually know the digital environment well?
Yes and no. I think, like, for my son and my daughter, the pediatrician that we have seems to navigate it pretty well. But I think that, he's had a electronic health record in his clinics for 7 years. One of the first waves of St. Luke's, when they adopted an EHR, was back in 2013. And so, when you go in, you can see, that maturity, I think, in 7 years of using an EMR in a meaningful way, day after day after day. But I think, to your point, I think there's definitely still organizations, clinics, physicians that just have not necessarily adopted it as easily. And it's still challenging. But I'm really interested in what you're saying around this kind of like technology. What'd you call it? Kind of those brute force of technology. Like, it's always interesting to me, like, when our society is taking in like this big transformational change, and it's hard to make heads or tails. It's very uncomfortable. Like, it very is uncomfortable to have your life disrupted in a way. Or I think what a lot of people are butting up against is being told. Right? Being told they have to stay inside, being told they have to use a piece of technology to order their food, being told it's this constant barrage. And I think that's where some of this opposition is coming from. Like, what advice would you provide to those folks when that opposition is painted towards, say, COVID, especially around challenging numbers, especially around, you see whatever the death rate is versus, and you look at the numbers a lot more than I do. So I'm just looking for your expertise here. What's your perspective on that, knowing that there's a lot of people who are just kind of really tired of being told what to do?
We have some things we do every day that we're told what to do, and we don't seem to mind. Like, I drive on the right-hand side of the road.
Sure.
So do you.
Sure.
On healthcare, no shoes, no shirt, no service.
Right.
Can't get into a restaurant that way. We don't seem to rebel about this. That's actually a public health law, not a decency law.
Okay.
And so we have framed what we could do in this response so poorly and so inconsistently that people say, well, I don't know what to believe. And we've politicized these things that are quite difficult. And to regroup. You know, the Pandora's out of the box when they say, don't believe this, don't believe that, don't believe this. Well, the bottom line is, I do get frustrated when I hear people say, well, CDC can't make up their mind. Well, actually, a virus is living. It's a living organism that morphs based upon its ability to get more resource or have less resource. So just like anything else that lives, if there's more places to live, it grows. If there's less, it dies. So we have seen, for instance, in the East Coast, the COVID has morphed to be much more of a respiratory issue. On the West Coast, it seems to have morphed to be much more not only respiratory, but neurological. So we see the disease morph. So when CDC does have different information, oftentimes it's a direct result of the condition morphing. And at the same time, our knowledge of this condition has changed. So whereas our death rate might have been much higher up front, we hadn't learned yet how to respond. We hadn't learned yet how the symptoms differ among people. An example, we would have a better death rate today with younger people than we did perhaps in the beginning. Now, or stated more positively, more people are living.
Okay, yeah, sure.
So what that means is that, for instance, if you're a young, healthy person and tomorrow you wake up with a headache, you don't really have a fever, but you're feeling some chest compression, you're feeling shortness of breath, and you just think, I worked out too hard, or, you know, it's allergies. And so there's not a top of mind to understand that that shortness of breath could be something that's very, very serious. And so oftentimes in the early days, young people who would get blue lips or signs of not having good circulation would arrive at the hospital in very critical conditions because they really were suffocating. So we've learned now that there are other symptoms to look for. And so we have a condition that's morphed. We have a response to that condition that's morphed and learned. And then we also have a wide, you know, really widely variation on responses of individuals. The bright spot has been when people self-manage, everything gets better. When people self-manage, there are less people in hospitals, there's less infection rate, there's less death rate. And so the big message should be self-management saves. Instead, what we're saying is that it's irrelevant and difficult. When in fact we know, you know, as the vaccinations come in, we're expecting a 60% efficacy rate. Okay, that's 60% of the time you're exposed, you're not going to get it. 60%. So we will, even with 660 million vaccinations that will come out, we'll have waves of delivery based on a cadence of supply chain that includes keeping that vaccination at sub-zero temperatures, which is complexity all in itself. We'll see supply chain difficulties. We will see with that efficacy rate that this will be with us, even with vaccination, a year or two, where we will not only get a vaccine, but still have to mask, still have to social distance. And so we're not educating people around a long-term, all hands on deck approach. We haven't done that yet. And we look at a nirvana being just a vaccine. And the fact of the matter is, health is public in a pandemic, and we all have to work to have health, have the public better. It's not by individual decision mandate. So it's a very confusing and very difficult time. And even with the vaccination, unless people are educated, unless folks have a chance to make some decisions themselves. So part of autonomy is making decisions. So I would hope a decision might be, I've done self-triage, I'm not high risk, I should be on that third wave of vaccinations. And I'd like to schedule that vaccination at Walgreens on Tuesday, 6 months from now, and know that I can. So making decisions about what's good for me and when I need it has to start now. And as we've not really thought about the person or the individual yet, we've thought about supply chain. Now what?
Right.
Right.
Yeah,
You
there's
do
a
the
whole
math.
ecosystem around the individual, right? And that's something that you're certainly your career path and trajectory and the things that you've done certainly lean into that individualized touch in healthcare. So you're saying personal ownership of just kind of like understanding what your risk factors are. Are there other things that you may want to be considering now as an individual sitting at home, maybe listening to this podcast? Like how should I feel about a vaccine that, it seems like it should take vaccines a really long time to be developed. This is, in the matter of 6 months. I know some of the best and brightest minds are the folks who are working on these kinds of things, but how would you respond to somebody who's saying something? And I don't mean to just be all about COVID today, but this is just such an interesting conversation. Someone's saying, hey, I'm going to give it a bunch of time. Like, I don't want to be in that first round. I don't want to, I'm nervous. So what if I get it?
I think that there's things that are worth being nervous about and things that are not being worth nervous about. So for instance, if we say that it does take a lot longer time to create a vaccine in our normal world, absolutely. And in fact, if we look at our flu vaccines today, that's built upon 20 plus, 30 plus years of knowledge. The COVID virus is called the novel COVID, novel because it's new. We haven't seen it. SARS is a derivative of it and others. This is the 19th derivative of this new coronavirus. And so with regard to the vaccine, when you have a long history and you can build upon existing knowledge, then we have vaccines that are 90% effective. So for instance, I go to get my flu shot, and I know that 9 times out of 10, when I'm exposed to the flu, I'm not going to get it. But it's not 100%. So the speed of this vaccination is more about, we don't have years to build upon. We don't have years of knowledge. And so the efficacy is 60%, 70%.
Okay.
So the fear to me is not about, is this vaccination well tested? Although there's some concern there, obviously. Will I get a vaccination that I know will be 60% effective? The answer for me is yes, because the consequences of not having any sort of immunity towards it is very, very high. And being able to know that I won't get it is one part of having a vaccine. But vaccinations are really about making sure your population doesn't die. It's about the mass. So my father was orphaned by the Spanish flu in 1918. It came through Idaho. They think killed 20, 30 million people. I don't know how many millions of people this killed. But in Little Rupert, Idaho, my father was 2 weeks old, orphaned, and his mother's sister was killed and her newborn. So in a little teeny place in Rupert, Idaho, then they had several cousins. Of the 25 people there, 12 were killed by the virus. And it was all over the world that way. So we don't see the death rate because the Spanish flu was more like Ebola than it is Corona. But we do see a disease that there's not a lot of knowledge about. So our death rates were higher, mortality was higher initially than it is today. But now we have more people coming in and overwhelming the system. Overwhelming the system doesn't mean there isn't enough beds. It means there isn't enough healthcare workers to spell each other, to make sure that they're not getting the virus, to be able to support and help. So vaccination isn't just about me as an individual. It's about saying, of the virus coming into the city, 60% of the people will survive. And that's, vaccination is about public health, and health is public. In a pandemic, especially highlights this. Our ideas of episodic care and population health were about disease-specific, diabetes, all the rest. A pandemic is not episodic in that nature. It's public. It's all tides rise all ships. So we have to have some vaccination to rise all ships, or we will be an uneven tidal wave addressing all of us at different times for years.
Leslie, thank you so much for that perspective. And yeah, it's such an interesting time, such a strange time that we're in, and certainly fortunate to have folks like yourself who are having meaningful conversations about, how to support individuals, how to support communities as we progress. We spent a lot of time talking specifically about COVID. One of the reasons I wanted to have you on actually was just to talk about like leadership and your career path and some of the things that you've done, and maybe some advice for others out there. You have had a tendency of going where the need is. That's what I've noticed about you. I noticed that you went to a complex space in technology first, and then found yourself in healthcare in an executive level position, leading change in healthcare. And then you kind of see the need is more upstream toward the patient. Maybe take us on like kind of your thought process through that journey. I'm so interested by it.
We've done a better job in many ways with the patient, educating people, using the digital world to help educate people and elevate them, to increase their intellectual capital. That's always been an interest of mine. How do you use technology to increase intellectual capital? When you are intellectually curious about something, you don't say, was that visit number 5672? Or was that 3514 that she presented with problems on her right hip? We think about, how many times has this patient come in with complaining of pain on her right hip? So I'll give you an example. Did a project years ago, was trying to convince providers that claims data had information. And we had a patient, we did a random sample of patients from claims information and medical record information. And on the right side was a claim. This is all web-based stuff. And then there was the hospital, and then there was the outpatient area. And this patient had presented with back pain, lower right side. And the physician that was looking at this, all of a sudden, I didn't know anything about clinically, moved from across the room, came over and sat in front of the computer and took over my mouse. And he started looking at what was going on. He said, oh my God, oh my God, oh my God. I said, what is it? What is it? So what he had discovered is on the hospital inpatient information, this patient had stage 4 ovarian cancer, and she was probably not going to live very long. She had complained of pain on her lower right side for over 7 years, and she'd never had a cancer rule out. The claims showed that she'd seen her chiropractor and her primary care, and they had all treated it as if it was a muscle pain, and there were no cancer rule outs, no testing, no imaging done. And so this was an example of going to where the need was with leadership, saying there's more information here. How can we use this to elevate the intellectual capital of the user? So I think my career shift has gone to the need to elevate patients, and how as individuals can we care for ourselves, coordinate our care better, have access into information. So it's not been easy. That example, even though with that kind of room, I couldn't get the funding to support integrating the claim into the record for the doctor, even with that kind of an example. And it's frustrating. So as a leader, even in technology, it's frustrating often to find a problem, solve that problem, but not have your audience ready to hear it. And that is something that's been hard. I had a great lesson from a friend of mine who was actually on the board of directors at St. Al's at the time, and he was the CIO of Albertsons. And I had presented to him all these wonderful new technology things I was going to do, and used all the right acronyms. Thought I was being cool. And he said, Leslie, I wouldn't give you a dime. And I said, what do you mean you wouldn't give me a dime? He said, you have just asked for money for nails and steel girders and all things to build a bridge. You haven't told me why the bridge needs to be built. He said, so you instead, as a leader, you describe the benefit. For instance, you have a river, and this river separates cities, and there are family members on both sides of the river, and there is a prosperous city on one that has great opportunities to grow and develop, but doesn't have enough people. And on the other side of the river, you have family members who don't have a prosperous city and don't have jobs. And they struggle to get across this river. But someone with vision has decided to build a bridge. This bridge will connect people to jobs and families to each other. This bridge will provide economy for both cities and parity for all involved. Let's build a bridge. He said, Leslie, you never described the steel girders and the nails and the people. You described the benefit. And that lesson has stuck with me in leadership so much that I rarely describe the nuts and bolts and always describe the end vision benefit. And unless you can describe an end vision where people are willing to follow, you are not a leader. You're just a taskmaster. And I'd say that's the biggest difference is going to where the need is and then creating followers, not going to the need and creating tasks.
I love that. I think everyone listening should take some time and listen to that bridge story again. That's I definitely will. That's pretty powerful. And just, I think a lot of us may do things like that where we feel like we're expressing the why, but having a story to anchor in like that and like really thinking about, how to provide a narrative that allows people to see the vision that you're putting forward is what a skill.
In tech, you see people talk about the problem and the solution.
Yeah.
No, I'm sorry. You have a problem. You might have a solution. Then what?
Yeah.
What does that solution give you that you didn't have before? If it doesn't give you more than just solving the immediate problem, you might have done the wrong thing well. So it's not about a problem and a solution. It's about a problem and a vision and a mechanism to solve it and to thrive as a result of it.
Yeah.
So how will I thrive when I solve this problem? So the solution becomes the mechanism to thriving, not the solution in itself. So I see people present, especially in technology all the time, the problem and the solution, whatever. So when you do that, then somebody says, so how much is it?
then you can have the money conversation, right? That's awesome. Well, hey, I've got another thing. I want to go back to a point that you made a little bit earlier around patients' rights and things that you've been involved in. I think maybe there's an opportunity here to unpack what that means just a little bit more. And, as kind of a public service announcement sort of thing here on the Jake Blanchard podcast, maybe you could, what is a patient's right? Like, what should an individual, me and my family, what should we know about our healthcare experience, our journey, what information we have access to, what we can ask for, like all those types of things that may just kind of get overlooked and all the static and noise of all the other things that we're forced to pay attention to?
Well, first of all, under HIPAA, which everybody gets told that's how you keep things private and sequestered, many patients are told, I can't give you that with HIPAA. Well, actually, HIPAA is the right of access. The right of access and portability of information. And so as an individual, you have the right to your entire medical record at your request with not unreasonable effort and at not unreasonable costs. You have the right to that digitally if your doctor or hospital is using any sort of funds from the federal government, an electronic medical record, you have the right to that digitally. It cannot be prevented. In fact, you have the right to have information sent to you in an unencrypted, non-secure way. If you want to have it sent to daffyduck@gmail.com, you have that right, and it cannot be prohibited. Now, the provider could say you need to sign this form and consent to it because they are actually sending your little electronic information in a way that's unsecure, but you have the right to make that decision. You also have the right to be able to have an app of your choice with no special effort connected to the electronic medical record minimum data set. So this data set we have defined under the law that is that you have access to. Now today that is for apps that can connect to the electronic medical record. It's called the United States, I can't remember the acronym, but it's the US CDI, which is basically the data set that's required under the law, the minimal data set. The provider has to give access to the app of your choice. Many electronic medical record companies are creating their own libraries of apps that connect to a much broader amount of data. So we will see the Apple apps of the world coming on and connecting to a minimal data set, but the electronic medical records companies like Cerner and others will provide a broader set of information on apps that they choose. So this app economy is coming to healthcare, and you have the right, with no special effort, to have the app of your choice connected to the minimal data set. And you also have the right to say, I agree to these services, but I do not agree to these services. You have the right to make a choice. I'm advocating right now on a project to eliminate no surprises. There are 30,000 surprise bills a day. Patients who think they're covered by their insurance. But if you go to the hospital with a scheduled event and you have been told that it's covered, and your anesthesiologist gets sick and is replaced by someone else who's not in the network, that second anesthesiologist has the right to charge you whatever they choose because they're not in that network. Sometimes we see this as thousands of times the amount that they would accept in Medicare. And it's creating bankruptcies. We're actually incarcerating individuals now for not paying their medical bills. In Nebraska last quarter, we had suicides. People who can't pay their medical bill. So these surprise bills are very, very difficult. I would advocate as an individual, when you sign for your consent to treat, you say, I consent to treatment within network. Anything out of network, I will pay 150 times Medicare, and put that right in your signature block. So the healthcare, unlike any industry, does not have the principle of mutual assent. That principle in the law says that if I hire a plumber and that plumber says it's $50 an hour and plus parts, and he's replacing your water heater, and the water heater costs $700, maybe at Home Depot, and you get a bill for $50,000 and you refuse to pay it. You have the ability to fight that bill under the principles of mutual assent that says, that's way beyond fair market value, buddy. I'm not paying you that. We don't have that in healthcare because nobody knows what fair market value is. And so what I'm advocating is that financial harm is something that should be included in the quadruple aim. So first, do no harm should be clinical and financial. And we can do that by providing transparency and also choice for patients who say, I will pay you, but I need to pay you under these principles of mutual assent that says there is some sort of fair market value cap. Because without it, we're seeing bankruptcies going through the roof. And COVID adds confusion to that. People don't understand. I go to the hospital with COVID. Is that in network or out of network? What are my responsibilities? Why am I paying for this? The government's paying for something. There's huge confusion around the responsibilities of the individual.
So is it 150 times Medicare or 150% of what the Medicare cost is? I'm sorry.
150%. Sorry, 150%.
Okay. Yeah. I was following because when you get that example on the water heater, I'm like, I think he's still within the billing range of 150 times Medicare.
Out of network has to be supported by a point of reference, and it could be 50% higher than Medicare up to 75% above Medicare, and in that range is acceptable. So Maryland has created a fair market value equation using referential billing, and that is a smart way to adopt an approach that keeps the idea of fair market principles and keeps the idea of negotiating network value, but also doesn't play whack-a-mole with finances that always end up on the head of the patient.
Of course. Wow. Well, Leslie, we've covered a lot in 45 minutes. Time absolutely flies by on these podcasts. What I usually do with guests is just kind of offer up the last kind of a closing. Is there anything that we didn't touch on that you think folks should know? Anything that you're advocating for? Any websites or places that individuals should go that you think are of specific interest, especially in the times that we're in today?
Well, I would really advocate people to look at the CDC themselves and not look at the news interpretation of the CDC information. And I would suggest that changing information means that it's current information. We don't expect our news to be stagnant. We should not expect our information about this pandemic to be stagnant. It's an unrealistic expectation. And then I would also advocate that if you're in tech leadership, talk about the bridge and learn that story and really understand how you can convey your ideas. And then I would say, wear a mask, social distance, use hand sanitizers, do your part. This is not about you. It is about all of us. And America's the best when we consider all of us and the worst when we don't.
Wow, Leslie, wise words. Hey, I certainly appreciate your time. Again, I just, want folks to know that I had the pleasure of working with Leslie at a previous employer at HealthWise. The times that we crossed paths, Leslie, and I got to travel with you a little bit, was absolutely one of my favorite parts of my career thus far. You were always a wealth of knowledge and somebody who's encouraging and positive, and really let me tag along in some meetings with you here and there in DC as well. So thank you so much for your time and your encouragement through my career. And thanks for agreeing to come on the podcast today. It was an honor to have you on.
Thank you, Jake. Good luck. See you later. Stay safe.
Cheers.